It's now my pleasure to introduce Louise Locock, who is an associate professor and director of of applied research at the University of Oxford. Locock employs qualitative research methods to understand health and illness experiences and use of these experiences to develop more patient-centered policies and practices. So that will be interesting to hear about. Thank you.
Thank you. So, slight change of gear now. I'm going to talk to you about qualitative research and patient involvement. What I'm going to tell you about is a little bit about some resources that you may find helpful if you're thinking, how do we do patient involvement? What does it mean? I'm going to talk a little bit about what we understand by patient and public involvement and why it matters, and then have a look at just a few of the debates around patient involvement in research. And I'm going to illustrate that with some data from our two interview studies that we've done, one with patients and members of the public who've been involved in research, and one with researchers and research managers about their experiences of trying to involve the public. I'm not going to say much about that, but I think you might be interested to know that some of them are really struggling with it, and some of them feel quite ambivalent and worried about what to do. The interviews that we do are recorded on video or audio where people agree, otherwise they're written only. And we put summaries of the findings on a site called Health Talk. This is normally for people talking about their experience of particular conditions. So there's people talking about cancer and heart disease and diabetes. In this case, we have a section on people's experiences of medical research, and that includes people who've taken part in clinical trials, in biobanking studies, and now these two studies on patient and public involvement. And if you go onto the site, what you'll find is summaries of the findings by topic. Those are down the left-hand side, illustrated with video and audio clips in the same way as in a qualitative research article you'd have data extracts. These are video data extracts. We've also done a summary of these findings for researchers. The work was commissioned by the Oxford Biomedical Research Centre, and with their support we've produced a kind of a PDF with details of what people said, and that's publicly available, and these slides will be publicly available as well, so you can check that out if you'd find it useful. So what is patient and public involvement? In the UK, we have the National Institute for Health Research set up a body called Involve, and they are there to promote patient involvement in research specifically. And they define it as research carried out with or by members of the public rather than to, about, or for them. And when they say public, they mean that broadly to include patients and family members as well as your average person on the street. I think it's helpful to try to distinguish three different things because they often get blurred. So participation is where people take part in a study, and we've just been hearing about people taking part in a genetic study. Involvement is where people are actively involved in research projects and research organisations such as ethics committees and funding bodies. And then there's engagement, and I think particularly engagement and involvement often get confused, but engagement in the NIHR, our National Institute for Health Research terms, is telling people about research. It's sharing information, it's improving science education, essentially. Now, those are all important things, and they all link together because people who take part in research are often the people who then go on to be involved. They're a great recruiting ground for people who would like to get further involved and become research partners with you. Engagement is also important because this is complex stuff, right? I mean, there was a lot today that I haven't understood. So if you're going to be involved in this kind of thing as a layperson, you're going to need a lot of support in understanding what all of you researchers are doing. So our Chief Medical Officer, Sally Davis, famously said that this was the primary reason for involving people. No matter how complicated the research or how brilliant the researcher, patients and the public always offer unique, invaluable insights. Their advice when designing, implementing, and evaluating research invariably makes studies more effective, more credible, and often more cost-efficient. I think this is quite an interesting statement because we live in a very evidence-based world, and it looks as though it's talking about an evidence-based model of effectiveness, that you can see a direct impact. But actually, there isn't that much evidence that patient and public involvement changes research always for the better in this way. I think we can sum up the reasons for involving people primarily as these two things, but I will come on to a third. So doing the research right and doing the right research. And in the UK, and I understand here in Norway as well, over the last couple of years, it's become mandatory, basically. You have to do it in order to get funding. So that's one reason to do it. You're not going to get your grant if you don't do it. But that's maybe not the best reason. Or maybe it is. So, doing the research right. I think this is around making sure that researchers explain things clearly and that if you have participant information sheets, they're understandable, that people are able to give properly informed consent. You might advise on research design and suggest to researchers that actually if they're trying to involve school children, holding clinics in the middle of the day perhaps isn't a very good plan, that kind of thing. They may also get involved in helping to collect data and analyse the findings from a patient perspective. And they may also hold you to account to make sure that you tell people the results. One of the things that people who take part in research are always saying is, we want to know what happened, and nobody ever tells us because it's 5 years down the track by the time you get your peer review paper out. Doing the right research is kind of at the other end of the spectrum. It's getting involved in trying to challenge what gets done, set the priorities for important research questions. So we have the James Lind Alliance in the UK who run what they call priority setting partnerships, where they get patients and clinicians together to identify unanswered questions that they would like to see addressed in new research. And then if you're a researcher and you see this list has been agreed, you can include that in your application and say, this has been jointly identified as an important topic. They may raise the profile of particular conditions or symptoms. They can perhaps particularly help in saying, these are the outcomes that really matter to us, rather than the ones that you're measuring. So when you're designing research, you should be paying attention to this. So famously, one example of that is in rheumatoid arthritis, where the patient-reported outcome survey didn't include fatigue. And people with arthritis said, fatigue is the biggest thing for us. So they changed the outcome measure. And they may also challenge wasteful or unnecessary research and say, we actually don't think that's a priority. Let's do something different. Finally, you might say, well, it's just the right thing to do. So are you doing it for this instrumental reason that it makes research more efficient and relevant, or just because we ought to? Because these are the people who pay taxes, they're the people who are our citizens, should they have a democratic right to say what happens? And if you take that view, maybe involvement isn't about what works. There's a broader political question here. So this leads me on to the impact debate. Measuring the impact of patient and public involvement generates a lot of interest, and there's lots of checklists out there for how we might do this and what we might measure. And there are good reasons for doing that. It costs a lot of money and a lot of time. So if it's not making any difference, is it actually ethical to continue doing it? But there are concerns about whether we can or indeed should measure it, and how do we capture it, particularly if what research is about is bringing lived experience into the research committee. Some of you may recognize this person. This is Carl Hennigan, who is the director of the Centre for Evidence-Based Medicine in Oxford. And so he's very committed to trial methodologies. And this is what he said when we interviewed him about researchers' experiences. As an evidence-based medicine person, they expect me to say, where's the clinical trial evidence? But that's not everything. You just can't run a world like that. Some things are pragmatic, make sense, and actually are a good idea. My experience is it'll improve your research. So that's, even from an evidence-based medicine specialist. So perhaps sometimes it's less about improving specific research processes, but more about changing attitudes and hearts and one's whole stance to research and why we do it. So this is Catherine talking about how she tries to bring that lived experience. And she says, being the person who walks into the room who is terrified for their own or their child's health. You don't know what it's like until you've been that person at home, trying to eat a dinner and throwing up at the thought of the person opposite you dying. You don't understand that till you've been it. And it's till you've been it. It's something that's really embodied, and that's what she's trying to convey to researchers. Another role that people talked to us about was this asking the so-called stupid questions. People used words like stupid, foolish, idiot a lot in their interviews because they're positioning themselves as the naive person, but often in quite a knowing way, that by doing that they can then go, aha, got you. So here's Roger, who says, I'm just an ordinary chap, but I'm an expert in my field as a carer. I have a contribution. The academic can get so wrapped up in the academic side of things, they sometimes miss the fairly obvious, ordinary, everyday, common sense answer. I enjoy surprising them. I regard it as a challenge. Perhaps I'm a congenital anarchist. Now, I think there's a worry about this cycle of tokenism that, a lot of us struggle with doing patient involvement well. And some of us are quite skeptical about it. But there's a self-fulfilling prophecy here. So this is people saying, PPI is a waste of time, I know what I'm doing, I'm the researcher, I'm the expert. Well, we have to do it, let's just get 1 or 2 people on our committee. They're poorly trained and poorly supported to make a difference, so they make little contribution, or even worse, they get angry because they feel excluded. And then the result is, see, I told you it was a waste of time. They just had an axe to grind. They were just annoying in the committee. This is David, who runs a clinical trials unit in Oxford. And I think this is a nice example of someone who used to have a fairly tokenistic attitude who has changed. So he says, we have what I would call tokenism. We felt we knew best and set the research questions. As an afterthought, more or less, then we'd better have a patient rubber stamp it. And that process involved picking a friendly patient, perhaps one of the clinicians or myself had seen, bringing them in to sit in a committee meeting, probably without the expectation of a great deal of involvement. It was ever so slightly patronising, I suspect, and it didn't embrace what we now know as proper PPI. As academics and clinicians, we tend to think we know what's important to patients, and that's often not the case. It makes me realise that what we think we know, we don't, and the patients often tell us something entirely different. And going back to the measurement and impact argument, this is Kath, whose son died of a neurodegenerative condition in his late teens. And she became involved after his death as a way to try and make sense of her life and find a new way of being, she puts it. But she explains that if public involvement is embedded, it's quite difficult to pull it out and say, what difference has this bit made? If, for instance, you're holding workshops where people are talking with each other, it's quite difficult to pull apart whose contribution made which difference. So these things make it quite complicated. And I think simplistic tools for measuring impact can be quite damaging. So I think this is a really nice example of the difficulty of measuring. The better the involvement gets, the more of a partnership it is, the more difficult it is to single out whose impact you're talking about. And in a way, why do we single out the patient? Why do we never measure our own impact? Do we measure the health economist's impact? So just a few more debates to whet your appetite, and I hope we'll talk more about these in the workshop this afternoon. So whether or not you should pay people for their involvement. In the UK, we are advised by Involve that we should pay people an honorarium as well as their expenses. Now, some people feel that's really important and that if you don't pay people, you're excluding some people for whom it would otherwise be difficult to get involved, and that it also recognises your equal status in the room. Why should you be the only person who doesn't get paid? However, there is a counter-argument that it undermines voluntarism and it may attract the wrong kind of people, whoever the wrong kind of people are. And perhaps, on the more positive side, that not being paid enables you to speak truth to power, that you're not part of the hierarchy, you're not beholden to the research community. There's a lot of debate about professional involvement. Do we have people who are, they've become accultured to the research community and they're tame and they've become too much seeing things through the researcher's eyes, being on their side of the table? Do people lose touch with the patient experience? But I think going back to my point earlier about the complexity of a lot of research, unless we have people who've got experience and knowledge and confidence to maybe challenge and stand up to us, are we actually getting real patient involvement? Maybe those naive patients that people say they want are more tame than the people who know a bit about research. What is representative is another worry for people, because if you're brought up in an evidence-based world, you want a kind of representative sample, but that's not really what we're trying to do. Even though we're trying to get lots of diversity of opinion, we're not really aiming for somebody to be a representative. It's about a different set of skills, helping people to see things differently. And again, who is expected to be representative? So Derek here says, how representative are you? Because if there's a GP at the table, are they representing all GPs? Is the nurse representing all clinical nurse specialists? And so on. So he says he likes to think of it as being not representative, but a representative. Like the word representative used as an artist, it's a representation of a jar. It's not a jar, it's a representation of a jar. But he then goes on to say that he likes to keep in touch with a wider set of perspectives by going out and talking to support groups. So just finally, other barriers that I think we may well touch on this afternoon. I do think there is a problem with patient involvement often being delegated to the junior person, and that person is often female. So I've got one researcher in our researcher sample who says, basically it's like, you're a nice young girl, you can go and make tea and have a cup of coffee and a cake with the patients, can't you? Devaluing its importance as just a kind of nice activity and a bit of a chat. Another thing I think is that we expect people to come to us. We bring them onto our territory where it's intimidating and it's a hostile place for them. Why do we not go out to where they are? Why do we not go out to a care home or to a support group and talk to people there? And why do we think that the committee and the reading and the meeting is the way to do this stuff rather than something more creative? So some enterprising people are using things like art workshops to get patient perspectives to inform their research. So I will finish there and say thank you to my colleague Anne-Marie Boylan, who helped with this research, and of course to all our participants and our funders. Thank you.
Very serious question.